Well, thank you, John. And uh, on behalf of myself and the CLL Society, I want to welcome everyone to what I think is going to be a great webinar. I'd like to start by thanking Lily for providing the educational grant for this program. We are joined by my friend, Dr. Matt Davids. Dr. Davids is Director of Clinical Research, Division of Lymphoma, Dana-Farber Cancer Institute. He's also an Associate Professor of Medicine at the Harvard Medical School in Boston, and I'm proud to say he's co-chair of the Medical Advisory Board for the CLL Society. As John mentioned, we'll be answering questions with Dr. Davids at the end of the webinar, so please take advantage of this opportunity and ask your questions in the Q&A box. Throughout the webinar, we will be providing a link for you to download the CLL Society's information resources in the chat section of this webinar. So please take a minute and click on that link and download the brochure. With that, it's my pleasure to introduce Dr. Matthew Davids.
Thanks so much, Brian. Hello, everyone. It's great to be with you today. I'm looking at the list of names here. I see a lot of familiar names. So hello, especially to my own patients who are tuning in, but also to everyone. And really have an exciting topic today to cover, which is non-covalent BTK inhibitors, which are a new targeted option for patients with relapsed or refractory CLL. I will say, because it's such a specific topic, I go into a fair amount of detail and some of the sophisticated molecular biology. So if, as we're going along, things are not clear, please jot down some notes and we will have plenty of time for questions. And I'm happy to clarify anything I say that may be unclear. All right, so these are my disclosures. I collaborate with most of the companies in this space, and I'll be discussing the use of most of the drugs in off-label uses. Just a shout out to the CLL Society to thank them for helping to organize this. CLL Society, under Brian's leadership, has really been a tremendous help for so many of our patients. It's an incredible resource that most of my patients take advantage of, and I really can't imagine caring for patients with CLL without the support of the CLL Society. You may not be aware of all the different resources that are available here. This is a summary, and I won't go through them in detail right now. You will have access to these slides, so you can download them and look at them in more detail. But just to highlight a few things, there's more than 40 different patient care and partner support groups that are being held virtually right now. There's a CLL medicine cabinet, which is helpful handout teaching sheets that we'll go through in a little more detail later in the presentation. And then one that's really personally meaningful to me is the Expert Access Program, which I participate in as a faculty member. It allows me to provide free online second opinions for CLL patients from around the country and around the world, and often patients who don't have access directly to a CLL specialized physician. And so it's been a great way to help educate patients and advise them about their cases, and something that we hope to be able to continue for a long time to come. All right, so with that as background, let me set the stage here. So this is really the diverse array of targeted drugs that we have that are highly active in CLL, and for the most part have now replaced chemotherapy-based treatment that we used to use for CLL. The big blob in the middle here is a CLL cell, and you can see some of the inner workings of the cell here with different proteins, which all have these different abbreviations. One really key principle in terms of the biology of CLL that unlocked all these new treatments is the interaction of CLL cells with what we call the stromal microenvironment. And that's the other cells listed there at the bottom. These are cells that are not so much in the blood, they're actually in lymph nodes and bone marrow where CLL cells are constantly circulating through. And that was really one of the key insights that led to the development of the new drugs, is that if we can block that interaction of lymph nodes and bone marrow with the CLL cell, CLL cells are not very happy and they'll die off. And so that's the principle behind blocking the BCR, which is the B cell receptor pathway. And there's kind of two main nodes there you've probably heard of, BTK and PI3K. So as we'll discuss, there's now 4 different BTK inhibitors. That's Bruton tyrosine kinase. You see those listed here: ibrutinib, acalabrutinib, zanubrutinib, and then the newest pirtobrutinib. We still have 2 PI3 kinase inhibitor drugs, idelalisib and duvelisib, that are approved, but not used as widely because they do tend to have more side effects. Then we have venetoclax, which targets a protein called BCL2, which is part of the mitochondria, which is the powerhouse of the cell. So targeting that really shuts the cell down very quickly, and it works in a very different way from the BCR pathway inhibitors. So these drugs work in a very complementary way to each other. And then there's also some proteins that stick off the surface of the CLL. You see those on the right. These include CD20 and CD19. We've been targeting CD20 for over 25 years now with drugs like rituximab and obinutuzumab, which are antibodies that stick onto the surface of the cell and help these other drugs to work better. And then a much more recent approval is just about 4 months ago in March, we had the FDA approval of liso-cel, which is a CAR T cell product. This utilizes a patient's own T cells, normal white blood cell, educates them to recognize a protein called CD19, which is on the surface of the CLL cells. And then these cells get reinfused into the patient where they can go and kill the CLL cells. So lots of tools in the toolkit now. What we're really going to be focusing on today primarily is drugs like pirtobrutinib, which is a new type of BTK inhibitor. But I wanted to give you the context of all the other therapies we have available to us. So as we kind of narrow down and think more about the BTK inhibitors, we have the 3 covalent inhibitors, ibrutinib, which was originally approved now about 10 years ago, and then acalabrutinib and zanubrutinib, which are newer drugs, approved about 5 years ago for acalabrutinib and just last year for zanubrutinib for CLL. And then the non-covalent inhibitors, pirtobrutinib was also approved last year, and then nemtabrutinib, which is not yet FDA approved, but is still in development. So why do we need so many BTK inhibitors? Well, they all differ a bit in terms of the proteins that they target. So that's really the biggest difference, and you can see that visually here. What these bullseye targets are representing is the different proteins that each drug targets. So you see starting on the top left there with ibrutinib, one of those big red circles is BTK. So ibrutinib is very effective at targeting BTK, which is what it's supposed to do. But you'll note that there's a lot of other big red circles there, and that means ibrutinib is also targeting a number of other proteins in the cell. And we think that that might lead to some of the side effects that we can see in some patients with ibrutinib, and probably doesn't help that much in terms of treating the CLL. And so that was really the incentive to develop the more specific or selective inhibitors, acalabrutinib and zanubrutinib. And you can see on the plots for those 2 drugs, they still have a big red circle where BTK is, but not a lot of other big red circles. And so these drugs still very effectively target BTK, but they don't target those other proteins in the cell. And so in theory, this should lead to fewer side effects. And that's now what we've seen in clinical trials that have compared each of these drugs, acalabrutinib and zanubrutinib, directly to ibrutinib. We've seen fewer side effects and still excellent effects in terms of controlling the CLL. So why do we need a 4th and a 5th BTK inhibitor? And the reason is that these non-covalent or reversible BTK inhibitors work in a very different way from the approved agents that are covalent inhibitors. And we'll talk about why that is and how that works in a moment. But just to give you a sense for the specificity of these drugs, pirtobrutinib, actually in the lower left, you can see is probably the most specific of all the BTK inhibitors at targeting BTK, has almost no effects on other proteins in the cell. Nemtabrutinib has a few of these off-target effects, as we call them, but also still very, very effectively targets BTK. So that's the main reason why we need so many drugs, because they all are a little bit different in terms of the different proteins that they target. So what's the rationale for this new generation of non-covalent inhibitors? So what I'm showing you here, and this is pretty technical, but bear with me. So the PH, TH, SH3, these are all different parts of the BTK gene. And what we found over the years is that when patients stay on ibrutinib or acalabrutinib or zanubrutinib for a long period of time, eventually the CLL will outsmart the drug. And it'll develop a mutation that can make the cells no longer sensitive to the drug, and so the CLL can start to get worse. And what we find on the right there is that these mutations tend to happen mostly in the same place, in what's called the kinase domain. And it turns out that's where these drugs target. So when they attach to BTK, they attach right there in the kinase domain. And so when there's a mutation there, the drugs can no longer attach to the protein. And so we think this contributes to the resistance that we see for all of these different covalent BTK inhibitors. And what we've seen is that the majority of patients who have to discontinue or come off these covalent BTK inhibitors like ibrutinib, acalabrutinib, and zanubrutinib are doing so because the CLL is progressing, it's getting worse, or they're having some kind of side effect. And right now, we don't have a lot of data from clinical trials of sort of what happens after that. We certainly have some data with the venetoclax drug. That's usually what we've been using sort of after patients have had a drug like ibrutinib or acalabrutinib or zanubrutinib. But increasingly, we're now also seeing patients who have had that initial BTK inhibitor and venetoclax, and now they need a 3rd line of therapy. And the outcomes in those situations are certainly not optimal, and there's been a need for additional treatment options. And that's really where the non-covalent BTK inhibitors come in. Anytime you see my term there, NC-BTKI, that's what I'm referring to. And we kind of have two parts now to the presentation. In the first part, I'm going to kind of give you more of a conceptual overview of what the non-covalent BTK inhibitors are, how they're different from the covalent BTK inhibitors, and then also show you some data on how effective they are. In the second part of the talk, I'll focus on the safety profile of the non-covalent BTK inhibitors. So let's start with pirtobrutinib, which is the approved non-covalent inhibitor. This was just approved back in December of 2023, so pretty new in terms of approval, although we've been working with this drug in clinical trials now for about 5 years or a little bit longer. As I showed you before, on the left side, you see it's very selective at targeting BTK. What you see in the middle there is what's called the drug concentration in the blood. And that dotted line that's just below 1 represents the level at which we think the drug would be effective. And so a nice thing about pirtobrutinib is that when it's given at the standard dose of 200 milligrams, you can see it quickly gets up into what we call a therapeutic range, and it stays in that range throughout that dosing interval for 24 hours. And that allows this to be a daily drug, like ibrutinib, which is similar. Remember, acalabrutinib and zanubrutinib are typically given twice a day, and they tend to have more of a spike, and they benefit from that second dose. But here with pirtobrutinib, single dose a day gets you in that therapeutic concentration. And on the right is sort of a diagram showing where pirtobrutinib targets BTK. I'm going to show you another slide in a moment, I think, that illustrates this point a little bit more clearly. So I'm not going to go through that cartoon on the right in as much detail. But I think, important takeaway here is that pirtobrutinib with a daily dose can get up to what we think is a therapeutic level. And we think that it can then target BTK. And importantly, it can target it even when those resistance mutations are present. And so this is the visual that I think is a little bit more helpful in terms of wrapping your head around how these drugs are different. So on the left is ibrutinib. And if you kind of focus on the little hexagonal structure in the middle, the yellow part, just below the word ibrutinib, that's the drug. The bigger ribbons, like the blue ribbon at the top and that greenish ribbon, that's the protein. And on the protein, there's a particular part called C481, which is a particular amino acid. And as you can see, ibrutinib is attaching itself to that C481. That's how it targets BTK. It targets C481. So when C481 is normal, ibrutinib is usually very effective. But what can happen is that there's a mutation at C481, and that leads to a change in the shape of the protein. And on the right, you can see that pirtobrutinib can actually still target effectively even when there's a mutation in C481. So you see how C481 is kind of in a different position. Pirtobrutinib doesn't care because it's targeting BTK in a slightly different way. And so that's why even in the presence of a resistance mutation, we think that pirtobrutinib can be a very effective drug. So with that science kind of underlying the development of the drug, pirtobrutinib was taken into a very large early phase clinical trial called BRUIN. It's a phase 1/2 study. Remember, in phase 1, that's where we're trying to figure out what's the right dose of a drug. In phase 2, we're trying to figure out how effective it is. And so they kind of combined 2 trials in one here with the BRUIN study. They recruited 317 patients with CLL. See, there were a variety of other B-cell cancers included. And in the phase 1 portion, they looked at doses from 25 milligrams all the way up to 300 milligrams of pirtobrutinib. And once we had data from that phase 1 portion, they determined that the optimal dose was 200 milligrams. And that's what they took forward into the phase 2 portion. So 200 milligrams once a day was the recommended phase 2 dose, and that was taken into the rest of the trial. Very busy table here. You don't need to go through it in too much detail, but I'll just hit some of the highlights for you. So as you see in the very top left, the average age for patients in the trial was 69 years, but there were patients in the trial in their 30s up until age 88 at study entry. As with most trials in CLL, close to 65–70% of the patients were men. And you can see at the bottom left that all of the patients had previously had a BTK inhibitor like ibrutinib, acalabrutinib, or zanubrutinib. Most of the patients on this study had also had chemoimmunotherapy, and about 45% had also had venetoclax. In the top right, in terms of reason for discontinuation of a prior BTK inhibitor, about 3/4 of the patients came onto this study because their previous BTK inhibitor stopped working, the CLL was getting worse. About 1/4 came onto this study because their prior BTK inhibitor was leading to side effects and they wanted to switch therapy. And then in the lower right, you can see that, remember I mentioned that C481 mutant. So about 40% of the patients on this trial had a mutation in C481 BTK, and about half of the patients in the trial also had deletion 17p or TP53 mutation, which, as most of you know, is a high-risk form of CLL from a genetic standpoint. So despite a challenging situation, a lot of patients without other good treatment options, the responses on this study were really amazing. And so what I'm showing you here as a visual is what's called a waterfall plot. So each line on this plot represents an individual patient. And the change here vertically represents how much their lymph nodes changed. And you can see almost all the lines are going down. So nearly all patients on the study had at least some shrinkage of their lymph nodes. We define a response as more than a 50% reduction in lymph nodes. So that's the lymph node shrinkage. So that's the dotted line there. And you can see that most of the patients, about 82% of the patients, achieved a formal response by having at least a 50% reduction in their lymph node disease. So very impressive activity. And the durability was also reasonably good. So particularly for patients who had not previously had venetoclax on the left, you can see that on average, they went about 2 years until they started to have progression of the CLL, so 2 years of pirtobrutinib. On the right, it was a bit shorter, 16 months on pirtobrutinib, but this is the double exposed population. So patients who had previously had a BTK inhibitor like ibrutinib, acalabrutinib, or zanubrutinib, and venetoclax, and then came on this study. And just to put this number in context, 16 months, for other treatments that we've used in this context, most patients might get 3 to 6 months of benefit at best. So seeing 16 months is certainly an important improvement in patients who didn't have a lot of other options. So again, pirtobrutinib can bind or target BTK in that kinase area. On the right is that cartoon again showing how it's targeting BTK even in the presence of the mutation. Now, one of the other things that's emerged in the field, and I think is an important story for patients to kind of keep your eyes on, is the acquisition of additional mutations. And so already, even though pirtobrutinib has been an important advance, we've started to see patients where the CLL is getting worse on pirtobrutinib, and we're trying to understand why that's happening. And this is some data that was presented by my colleague from Dana-Farber, Jennifer Brown, where they took a look at 88 patients from the Bruin study who had had worsening of the CLL, and 44% of these patients had acquired new mutations in BTK itself. And then there were other mutations in about a quarter of the patients. And if you look on the far right side there, this is kind of a list of all the different mutations in BTK. And interestingly, not many of them are the C481 variety where we saw that with the older drugs, with the covalent inhibitors. It's a variety of new mutations that we're now seeing after pirtobrutinib. And I think a nice visual comes from this, from her presentation here, where you can see on the left is the sort of amount of mutation in the patient at baseline when they started on the pirtobrutinib trial, and PD is when they had progressive disease or when the CLL was getting worse on pirtobrutinib. And you can see it very clearly, I think, on the left with the C481 mutations. Remember, there were quite a few patients who came into the study with the C481 mutations, and as they stayed on pirtobrutinib, the level of those mutations went down, which means that the drug was effective at killing off the CLL cells that had that mutation, just as had been predicted. But unfortunately, at the same time those mutations were going down, these new mutations I mentioned were coming up. So for example, T474, that's the middle panel, and L528W, which is the right panel. So don't get too bogged down in the different mutation numbers and names, but really just conceptually here, I think it's important for you to understand that certain BTK inhibitors are effective against certain mutations. Other BTK inhibitors may be more effective against a different panel of mutations, but then new mutations can arise. It's a little bit like a game of whack-a-mole. And so it's a little frustrating that we're already seeing some of these mutations coming up, but we have other BTK inhibitors in development that may actually be effective against those mutations. So we're always trying to stay one step ahead of the CLL. And so, I think that right now it's good that we have so many different options in terms of these drugs. I think that one thing that's probably not done so often right now in routine practice is actually testing for these BTK mutations. I imagine this will probably come up as a question in the discussion, so I'll try to head it off here. But I think a lot of patients may be wondering, should I be tested for these different BTK mutations in the clinical setting? I think right now it's not essential that everyone be tested for these, but I do think as we develop bigger and bigger data sets, eventually it probably will be helpful in terms of how to sequence these drugs. In other words, which one do we use first and second? It may depend on which mutations are present there. So I think it is something to kind of keep in the back of your mind that in the future it may be useful to test for these BTK mutations. But again, if your oncologist is not recommending that now, that's not wrong, because right now we're not really making clinical decisions based on this. We're really just doing it in the context of research studies. All right, so that was sort of the initial Bruin study, which was just pirtobrutinib on its own. But of course, even though the numbers look good, we think we can do better. And so already we've launched studies looking at combinations of pirtobrutinib with other drugs. This first one here is a combination of pirtobrutinib with venetoclax plus or minus rituximab. So you can see the orange cohort there is pirtobrutinib and venetoclax, just the two drugs. And then the green cohort there is all three drugs, pirtobrutinib, venetoclax, and rituximab. And this is pretty early days. You see here in this waterfall plot, there's not nearly as many lines. That's because there's only 25 patients so far in this combination study. But so far, I think it also looks very promising. So on the left side of the waterfall plot is the PV cohort. That's the pirtobrutinib venetoclax. On the right side is the three drugs, PVR. And you can see the blue bars represent patients who previously had a covalent BTK inhibitor, like ibrutinib, acalabrutinib, or zanubrutinib. The gray bars represent patients who had not previously had a BTK inhibitor. And you can see, again, all of the patients benefiting here, most of the patients having greater than a 50% reduction in the lymph node size. And overall, the tolerability of this combination has been good, as we'll review in the safety section. So I think this is exciting initial data. We don't know how long these responses will last for, but another way to kind of understand how deep the response is, or the sort of the quality of the response, is through MRD testing. MRD is either minimal residual disease or measurable residual disease, depending on who you ask. But essentially, the way I describe this is that we can look on scans, on physical exam, under the microscope, and we can sometimes see CLL. But sometimes when we do all those things, we can't see CLL anymore, but it may still be there. And that's where MRD can come in. It can actually measure these minimal amounts of disease that we can't see with the microscope, but it can detect it at a molecular level. And in this MRD analysis of the Bruin study, you can see in blue that as patients kind of stay on therapy longer, you see that blue converting to red. And red here represents undetectable MRD. And so at any point on this study, 87.5% of patients so far have achieved undetectable MRD at some point in the trial. And for all but one patient, they've been able to sustain that so far. So it's giving us a sense that the combination here of pirtobrutinib and venetoclax, with or without rituximab, is inducing very deep responses. And usually that translates into a very durable response for patients. These are the curves so far for progression, which look very good. But right now it's very small numbers of patients, and the patients have not been on study for very long. So I think it's very early to kind of comment on how durable the responses will be with the combinations. So based on all that promising data that I just showed you, there's been a big investment in bringing pirtobrutinib into phase 3 clinical trials. That's where a drug is compared to the existing standard of care therapies, and really trying to define the new standard of care and lead to full approval of these agents. And so there's 4 studies now in CLL, phase 3 studies with pirtobrutinib. One of them, the Bruin CLL 321 on the far left, is going to be the first one to read out. This is for patients who have already had prior treatment for CLL, so relapse refractory patients. And it was a randomized study comparing pirtobrutinib to either the PI3 kinase inhibitor idelalisib with rituximab or chemotherapy, bendamustine with rituximab. We expect to see the results of that study fairly soon. The second column is a study comparing the triplet regimen I just showed you, pirtobrutinib, venetoclax, and rituximab, versus the standard treatment, which would be venetoclax and rituximab as a doublet. And that study is ongoing. It'll probably be a while till we have those results. And then there's also studies of pirtobrutinib in what we call the frontline setting, meaning for patients who have never had CLL treatment before. The 313 study is comparing pirtobrutinib to chemoimmunotherapy with bendamustine and rituximab. That study is being done mainly outside the United States. And then the 314 study on the far right is a head-to-head study that's comparing pirtobrutinib to ibrutinib. It includes patients who have not had prior CLL treatment and patients who have had prior treatment. So quite a bit of research still going on with pirtobrutinib, and often the phase 3 studies are really the more definitive ones that lead to widespread usage of the drugs. So expect to see these starting to read out fairly soon. One study that's just getting underway soon in Europe is called CLL 18. I wanted to highlight it because I think it's a really interesting study. It's being run by the German CLL study group, and it has 3 different approaches here, 3 arms that are being compared. It's a randomized study. So the control arm, which is the standard treatment, is the venetoclax obinutuzumab regimen, which is a 1-year treatment. and it's being compared to one of two different experimental arms. So the first is pirtobrutinib with venetoclax, so the doublet regimen, and everyone in that arm gets 15 months of therapy, regardless of how they're doing. But arm C is an MRD guided venetoclax pirtobrutinib. So patients can get sort of 1, 2, or 3 years of the combination, depending on how quickly they achieve this milestone of undetectable MRD. With the idea being that patients who achieve it fairly quickly maybe don't need so much therapy, and then some patients may need more therapy to get into that deeper MRD state. And this is really going to be the first time in a randomized study that we've seen a comparison of a fixed duration strategy to an MRD guided strategy. So I think it'll be very informative for the field, but I expect it to probably be a few years until this study gets all the patients on and treats them. So something to look forward to in the future. All right, so pirtobrutinib is not the only non-covalent BTK inhibitor in development. There's also nemtabrutinib, and I'll show you some data from this drug as well. As I showed you earlier, this drug does target a few other proteins besides BTK, but it targets BTK very effectively. The numbers so far are a lot smaller than pirtobrutinib. So far we've seen data from the 57 patients in this study called BellWave 001. And what the different columns here represent are different types of genetic markers, for example, or prior treatments. And if you look across, generally this ranges from about the 40 to 60% range in terms of the response. So that's again the number of patients generally with lymph node shrinkage of more than 50% and improvement in their blood counts. And so far, this is translating into the durability of benefit being, I'd say, kind of in the same range as what we saw with pirtobrutinib. Cohort A of this study is patients who previously had a covalent BTK inhibitor and have a mutation, the C481 mutation. And the average benefit there is around 16 months, pretty similar to what we saw with pirtobrutinib. And so, I think it's nice to have different options in development, and there are some potential safety differences between the non-covalent BTK inhibitors that we'll review now. So first with pirtobrutinib, because this drug is so selective at targeting BTK, it is also very well tolerated. In this analysis of safety, the average time on pirtobrutinib was about 1.5 years, so certainly enough time to capture a lot of adverse events or side effects, as we call them. And it was pretty uncommon that patients would need to reduce the dose of pirtobrutinib. So that was 3.9% of patients who had to reduce the dose of the drug due to a side effect. And only 2.5% of patients had to stop pirtobrutinib due to a side effect. And on the right, you can see a table that lists some of the common adverse events or side effects. And any grade is really any kind of side effect. So anyone who complained of some tiredness would be lumped in the fatigue category. Same thing with neutropenia, which is a low white blood cell count, in terms of infection fighting cells, et cetera. So typically the ones that are more concerning are grade 3 or higher. Those are the more serious side effects. And if you look on the right side, in terms of grade 3 or higher side effects that were thought to be related to the pirtobrutinib treatment, really just neutropenia that sticks out, about 15%. And that's something that we can often fairly easily address by using growth factor shots like Neupogen or Neulasta, those sorts of shots. Unfortunately, when you have CLL, as you all know, infections are pretty common. And so infections were seen in close to 3/4 of patients in this study. And if you look at the ones, though, that were thought to be related to pirtobrutinib and more serious, it was only about 4% of patients. Some of the other side effects we're used to seeing with BTK inhibitors, like bruising, were relatively low, about 19% any grade bruising. So that's any bruising, and that was thought to be treatment related. Arthralgias, which is joint aches, also relatively uncommon, about 4% were thought to be related to pirtobrutinib. And some of the cardiovascular issues that we've seen with other BTK inhibitors, like high blood pressure, hypertension, and atrial fibrillation, were pretty low with pirtobrutinib, in the range of about 3% hypertension and 1% AFib flutter that were thought to be related to the drug. Now, when we combine the two drugs together, pirtobrutinib and venetoclax, we do see more in the way of side effects because we're using two drugs instead of one. Makes sense. We did see in this study a couple of cases of clinical TLS, which is tumor lysis syndrome. This is when the CLL cells burst open so quickly that they can release some of their toxins into the bloodstream, and that can be serious. One of the patients in this study actually required briefly a period of dialysis to help with that, but it got better. So we need to be very careful with these drugs to utilize them in the way that they're labeled and to monitor patients closely with frequent labs and so forth. But by doing that, it's very safe to give this combination. You do see higher rates of neutropenia that's treatment related with the combination. That's on the far right, about 47%, grade 3 or higher. They did see a little more in the way of diarrhea. We know that venetoclax can cause some diarrhea, and with the pirtobrutinib, I see that a little bit more. And then in the lower right, again, still infection rates are high. This is pretty true across the different regimens that we use in CLL. And then in terms of other cardiovascular side effects, those were pretty low with this combination. So overall, I'd say a very favorable combination in terms of the safety. And with the rituximab, it's really a similar story. The main thing that rituximab adds is some infusion-related reactions, which you see in the table kind of midway down there. That's kind of more of an allergic reaction that you can have when you're getting the rituximab infusion. It's usually pretty manageable with steroids and Benadryl and other supportive measures. It happened in about 40% of the patients in this study. In a couple of cases, it was more serious, but was reversible. So again, when we add 3 drugs together, we expect a little more in the way of side effects, but we certainly see excellent control of the CLL as well. Now, what about nemtabrutinib? I mentioned there was some good safety data from the Bellwave 001 study, and so you can see a summary of that here. One of the interesting side effects that comes up with nemtabrutinib is dysgeusia, which is not a common term, so I'll explain it. Basically, what dysgeusia means is it's an alteration in taste. Something that we've seen in the past with chemotherapy drugs sometimes, but not a common one that we see with the targeted therapies in CLL. So dysgeusia was reported in about 20% of patients, but as you see here, it was pretty mild. There were no grade 3 or higher events. And for most patients, this went away after they got used to the drug. So it was not a major issue, but it's certainly something that I'd counsel my patients about, just so that they're not surprised if they experience that side effect. You do also see the neutrophil count decrease with nemtabrutinib. About 17% of patients had more serious decrease in the neutrophil count, but again, fairly easy to support that with the growth factor shots. Hypertension in about 10%, and also diarrhea in about 10% of patients, but for the most part, this was pretty low grade. So kind of summarizing the safety portion for the non-covalent BTK inhibitors, pirtobrutinib, as I showed you, is a very selective non-covalent BTK inhibitor. And I think because it only really targets BTK, it's got a very favorable safety profile. The more common things we see are neutropenia and infections in terms of more serious side effects. But most of my patients who've been on it have really tolerated it very well. I have less experience in my practice with nemtabrutinib, but from the trial data that I showed you, you can see it's a little bit less selective at targeting BTK. The majority of patients tolerate nemtabrutinib very well, but there is this low-grade dysgeusia for about 20% of patients, and some other cardiovascular side effects that we need to watch for. Cardiovascular side effects, though, are really a concern for all of the BTK inhibitors. Even though these non-covalent BTK inhibitors have a relatively low rate of cardiovascular side effects, it's not zero. And we need to be particularly mindful of this in our older patients, those who maybe have other risk factors like myocardial fibrosis, which is like scarring from prior cardiac issues, patients who might have swelling, edema when they come in, or those patients who have pre-existing high blood pressure, hypertension. And those are patients who may need more close monitoring when they're starting on BTK inhibitors, and some patients may even require treatment with high blood pressure medicine, antihypertensives. And fortunately now, our cardiology colleagues have become engaged in this, and there's, for example, algorithms now for monitoring and managing cardiovascular adverse events or side effects, which has been published, and that's been useful for guiding oncologists as to how to approach some of these side effects. One final slide, because this is a question that comes up a lot now in practice, is what do we do for a patient who's been on a covalent BTK inhibitor, ibrutinib, acalabrutinib, or zanubrutinib, it's getting worse? Do we go to a venetoclax-based treatment, as we've been doing for the last few years? Or do we go directly to pirtobrutinib, and do we skip venetoclax? And I'll tell you, first of all, the label for pirtobrutinib is only for patients who have already had a covalent BTK inhibitor and venetoclax. So this is one point where I'll kind of flag, if you're being recommended to go on pirtobrutinib as your second treatment after just being on, say, acalabrutinib, that is an off-label use of the drug, although it is something that we have these guidelines, oncology guidelines called NCCN guidelines, and it is supported in the guidelines. So I think from a reimbursement perspective, most patients in that scenario have not had trouble getting the drug paid for by their insurance, but it is an off-label use. And so the question naturally arises, well, what's better? Should I get venetoclax as my next treatment, or should I get pirtobrutinib? And right now, we don't have a clinical trial that answers that question. And so the short answer is we don't know which is better, and these need to be individualized discussions between you and your oncologist, weighing all the pros and cons of both approaches. That being said, in the meantime, while we're waiting for trials eventually to hopefully settle this question, there has been an effort that I've been involved with to try to compare across the trials with data that we have with venetoclax already and data we already have with pirtobrutinib from different trials, and to do what's called a matched adjusted indirect comparison. What that does is it basically tries to match up the patients from the trials as best they can, weighting them for their, the age of the patients, the other medical issues they have, how many prior CLL treatments they have, to try to make the comparison as close as possible. And so when you do a MIAC and you compare the data from a pirtobrutinib trial with a venetoclax trial, you can see on the left that what's called the progression-free survival, which is kind of how long the drug works for, is quite similar between the two. You see those curves are kind of tracking whether the pirtobrutinib is kind of weighted for all those variables or unweighted. Patients can do very well with both approaches. On the right, you can see in the table that there are some differences in terms of side effects. You tend to see more of the neutropenia, low white blood cell count with the venetoclax-based approach. Probably see a little more in the way of cardiovascular issues with pirtobrutinib. So again, there's no right or wrong answer here as to what you should get after covalent BTK inhibitor. But I think studies like this help us to feel comfortable that both are good options and that you can't go too wrong there, and that it's good to have a discussion about both with your oncologist. All right, so kind of wrapping up some of the key points here, and as we integrate these new non-covalent treatments into our clinical practice with CLL. First, non-covalent BTK inhibitors may provide benefit for quite a few patients who have CLL getting worse while they're on a covalent BTK inhibitor, and the safety profile for these oral agents are generally favorable. Again, we don't know yet the optimal sequence of whether we should be starting with these drugs after covalent BTK inhibitors and then going to venetoclax or vice versa. So I do think, as with all treatments, patient preference is a very important factor. Starting venetoclax does involve more monitoring and visits and so forth, but has the potential benefit of being a time-limited therapy. Pirtobrutinib and nemtabrutinib are quite easy to start because they're oral agents. They don't need as close monitoring, but right now they're designed as continuous treatments. So I do very strongly encourage patients to consider actively participating in clinical trials. Even though we already have several good therapies for CLL, we're still working hard to try to optimize how we're using them. I think this question of venetoclax or non-covalent BTK inhibitor is a good example of that. So if you're able to get into a clinical trial, if you have access to that, I certainly encourage you to do it. It's hopefully going to help optimize your care and maybe help others in the future as well. So with that, just before we get into the question and answer period, I just wanted to highlight, as I mentioned at the beginning, there's this resource called the CLL Society's Medicine Cabinet. These are printouts of the different drugs, and you can see some of the things that are covered here, different indications, dosing, what to do if you miss a dose, common side effects. Right now, this includes 9 of the most common medications used in CLL. These are non-branded, and so they're very patient-friendly. And so you can ask your oncologist to print these out, or you can print them out yourself. You can see the website there. It's through the CLL Society. I tell you, thanks to the CLL Society, I have a bunch of these in my office now, and I've just started handing them out to patients starting on these drugs. So for any of my patients who are on, if you want these, I can hand them out to you at your next visit. And if you're not my patient, please ask your oncologist. I think especially when you're starting a drug, but even if you've been on a drug for a while, I think these can be a great resource. They're very concise. They're all about 2 pages. And really all the key information you need to know is right there on them. So certainly encourage you to use these. So with that, I'm going to turn it back over to Brian, and I think he's going to moderate our Q&A session.
Well, first, I want to thank you, Dr. David. There was a lot of complexity to these slides, and you did a great job of explaining them and walking us through them. And I'm very appreciative of that. There were a couple terms before we get into the questions that I just wanted you to explain to us that kind of flashed by. VAF, that seemed to be important in terms of mutations. Can you tell us what that stands for and why patients should understand what VAF means?
Yeah, so VAF is variant allele fraction. I didn't use that term specifically because it is a little complex, but you're right, it's an important concept. And I think the slide that maybe illustrates that best is the one I showed you where some mutations were going down and some mutations were going up. And what it's referring to is really the fraction of cells that are measured that have the mutation of interest. So when the VAF is high, it means a lot of the cells have that mutation. Therefore, it's probably more significant from a clinical perspective. When the VAF is low, might mean the mutation's still there, but it's less likely to be having an influence on the behavior of the disease because it's at a very low level.
And remind us again what neutropenia and thrombocytopenia are. Yeah.
Yeah, so neutrophils are a type of white blood cell that help you fight off infections. When they're low, we call that neutropenia. And again, that's the one that we can usually support if we need to with growth factor shots like Neupogen, Neulasta. Thrombocytopenia is a low platelet count. Platelets are little cells that help you clot your blood. So when those are low, if they get low enough, they can increase your risks of bruising and eventually risks of bleeding.
Well, let's get to the questions. And if we're not able to answer all your questions, you can email them to info@plexuscom.com. That's info@plexuscom.com. So we can put that up in the chat for everyone to see. So let me start with a question that seems important when we're looking at this class of drugs. And we've been very big, and one of our resources has been test before treat. And I wanted to get your sense of how important some things were in terms of how well these drugs do. Does it matter what your age is? Does it matter what your RI stage is? Does it matter about TP53? Does it matter about IGHV mutation status? Does it matter about other FISH tests, complex karyotype? Walk us through what we know and don't know about these with the, maybe with both the covalent and the non-covalent BTK inhibitors, and whether we should even be bothering to still test if they work well in all of these situations.
Yeah, so I think this is a complicated question, and it in part relates to where you are in your CLL journey. So if you're recently diagnosed and you're on an observation or active surveillance strategy, I find it very helpful for most patients to have this type of genetic information, because it really helps to kind of understand how likely it is that you're going to need treatment and when you might need treatment. And a lot of patients kind of appreciate that sort of insight into being able to plan their lives a bit, knowing that it's not perfect, but kind of gives you a sense for that. I think probably better than RI stage. As important as that has been historically, I think it's less important now that we have such good genetic predictors. In the frontline treatment setting, meaning patients who have never had CLL treatment before, but then need to start treatment for the first time, I also think they're very important, particularly the TP53 aspect. And remember, there's a couple of different ways that you can have issues with TP53. It can either be deleted on the FISH test, that's called deletion 17p, or it can be mutated, which would be a sequencing test. So that's TP53 mutation. And in both those cases, we generally are still thinking that it's better to be on a continuous treatment like a BTK inhibitor rather than a time-limited treatment like venetoclax-based therapy, like venetoclax or obinutuzumab, for example. So I find that to be helpful in that context. In the relapse setting, meaning for patients who've already had prior CLL treatments, kind of the focus of today's discussion, it's a little bit less relevant, I would say, for our older patients, because these patients would probably be candidates for pirtobrutinib, for example, if they've already been through a covalent BTK inhibitor and venetoclax, and that doesn't depend so much on their genetics. I think it is still very relevant for younger patients, and you can define younger however you'd like, but for patients where they might be, in a tough spot where they've been through a lot of therapies and they might be thinking about things like CAR T cell therapy or a bone marrow transplant from a donor, an allogeneic transplant, then having that information about the genetics, particularly that TP53 status, can be important, because that can help, make it a more sort of rational decision about whether the risks of those more cellular types of therapies are worth it. If you have low risk disease, maybe you try to ride it out with some of these other therapies. If you have high genetic risk disease and you're young, then maybe you do go for something more aggressive like CAR T or an allo transplant.
And let me just zoom in on the age question. Is there an age issue with the non-covalents? Are they safe? I think in one of the studies you mentioned up to 88 years old, you had a patient. Are these safe drugs for your elderly patients? Is that one of the advantages to these drugs?
Yeah, generally, yes. As you said, there were patients into their early to even late 80s on these studies who tolerated these drugs well. So yeah, I think these are great options for older patients. I would say, though, the average age on the study was more like 69, 70 years. So most of the patients were a bit younger on the trials.
And here's a general question about BTK inhibitors, and talk to me about the covalent and non-covalent here. If a patient gets into a remission, are they still immunocompromised? That's a big concern these days.
Yeah, so the short answer is yes. There's different degrees of immune suppression in CLL, and patients who are I kind of think of it in a few different categories. So patients who are on active surveillance, who've never had treatment, do have a moderate amount of immune suppression just by virtue of the CLL itself. To some degree, it correlates with how long they've had CLL and how much CLL is in their body, although it's not a direct correlation. When patients get a time-limited treatment like venetoclax or obinutuzumab, they probably are even more immunosuppressed in the early stages of that treatment and even for sort of the latter part of that year. As they get further out from finishing treatment, that immunity improves because they're getting further out from treatment, they're off treatment, and their CLL is in remission. So that might be sort of the peak of their immunity. Patients on BTK inhibitors, because they're on a continuous therapy, their CLL may get into a better remission. So that aspect of their immunity may improve, but there is still some immune suppression from the BTK inhibitor itself. I think the COVID vaccination story has been a good example of that. We find that patients who are on a BTK inhibitor have an impaired response to COVID vaccines. It's not a complete impairment, so they should still get vaccines. They still have benefits in terms of their T cell function and other things, but there is still some level of immune suppression. I don't see that as being too different between the covalent and the non-covalent BTK inhibitors. So I think that's always going to be there when you're on treatment.
So it seems to me what you're telling us is the BTK inhibitors or the non-covalent BTK inhibitors are helpful for people who had refractory CLL from let's say obinutuzumab and venetoclax. Are they also maybe you need to explain this because somebody's asking about this concept, helpful in what's sometimes called accelerated CLL? Can you explain that? And is there any experience with using pirtobrutinib or nemtabrutinib in that setting?
Yeah, so just in terms of definitions, accelerated CLL is when the CLL is starting to become more aggressive in terms of its clinical behavior. So the lymph nodes are growing faster, patients are having more significant symptoms. And often when a biopsy is done, for example, of a lymph node, there's a certain appearance of the cells under the microscope where they look like they're more aggressive. It is important to distinguish this from Richter transformation, which is sort of like a much more aggressive version of CLL where it's basically turning into a different lymphoma. And that requires a completely different treatment. What we find is with accelerated CLL, which does look different under the microscope, that these patients should be treated with CLL therapies and that the non-covalent BTK inhibitors like pirtobrutinib and nemtabrutinib are a very good option for those patients. And in fact, even though they didn't quite distinguish it in the presentations and the papers with pirtobrutinib, there were quite a few patients on that study who had accelerated CLL and went on to pirtobrutinib and responded well to the drug. So I think it is a good option for patients with that diagnosis.
There's a lot of sophisticated questions here, Matt, so I'm going to put you on the spot here. Talk to us a little about this evolution of mutations. Somebody asks about a gatekeeper mutation and whether pirtobrutinib would work in that circumstance, and kind of your sense of how those evolve and what the possibilities are for patients.
Yeah, so this I would say is still a bit of a murky area. We don't have a firm understanding on all of the implications of these different mutations, particularly because a lot of the initial data that we had was in vitro data, which means we took cells from patients with CLL and we treated them in a test tube with all these different drugs, and we saw how well the drugs worked. And that kind of gave us a certain pattern of, okay, this drug seems like it should work for this mutation, this drug for that mutation. Then when the drugs went into the clinic, we're starting to see, well, some patients have that mutation that it's supposed to work in and the drug's not working, or some people have a mutation where it's not supposed to work and it's working anyway. So that's where it's gotten murky, where the clinical responses have not always lined up with what we see in the lab. So a good example of this is the L528W mutation, which is some people are calling sort of a kinase dead, or it's really more of a kinase impaired mutation. What that means is when that mutation is present in BTK, it's actually not able to signal the way it's supposed to. And what we're finding is that other proteins may come along and sort of help with the scaffolding function and therefore allow the signal to still be transmitted. And so what that means in practice is that, for example, we would not expect pirtobrutinib to be that effective in the presence of an L528W mutation, and yet we've had examples of patients who've had that mutation who've had a good response clinically to pirtobrutinib. And same thing with the gatekeeper mutation you mentioned, which is the T474I. We've seen patients with acalabrutinib resistance who have had that mutation, but when we look at the in vitro assays, that's a mutation where acalabrutinib is supposed to work. So a lot of this may have to do with the fact that when we measure these mutations, we're measuring in the blood. And as we know, CLL is not just a disease of the blood, it also affects lymph nodes and bone marrow. And so I think in some cases, what we're measuring in the blood may not always be reflecting what's in the lymph node. The VAF that we discussed before, the amount of mutation may be influential. If there's a very low VAF mutation, that may not confer resistance. So lot to learn here still.
Let me ask you to speculate a little bit on this, because I know the research is just beginning, about the role of non-covalent BTK inhibitors frontline. Do you see that as something in the future? Because they do seem very clean and well tolerated.
Yeah, so I'm certainly excited about the studies looking at the non-covalent inhibitors in the frontline setting. In fact, we recently opened one here at Dana-Farber, being led by Dr. Inye An, which is looking at pirtobrutinib in combination with obinutuzumab as a frontline treatment and doing that as a time-limited therapy. So we also saw data at the EHA meeting in Madrid last month with a triplet therapy of pirtobrutinib, venetoclax, and obinutuzumab being led by MD Anderson. So there's a lot of exciting studies going on in the frontline setting. So I'm optimistic about it. I think especially for these time-limited regimens, it's going to be a really good approach. I think in terms of using pirtobrutinib as a continuous treatment in the frontline setting, although I think that could be a good therapy, I think it's going to be harder to sort of demonstrate that that's better than starting with a covalent BTK inhibitor. It's not that it may not be, it's just that it's going to take a long time to generate the data because patients will do very well, which is great. But I'd be curious to then see how do patients do with drugs like ibrutinib, acalabrutinib, or zanubrutinib in the relapse setting after frontline pirtobrutinib. And I'd really want to see that data also before I'd feel more comfortable using pirtobrutinib for most patients in the frontline setting, because we know the other way works, right? We can start with acalabrutinib or zanubrutinib, and we know that pirtobrutinib will then work for most patients as a second treatment. We don't yet know the other way around. We certainly think that they can start with pirtobrutinib and then respond to the other BTK inhibitors, but it would be nice to see some data in that respect.
Very specific question. If the CLL is in the liver, which it can happen, and you and I have both seen patients like that, is there a reason to believe that pirtobrutinib would work in that case?
Yeah, it should work in that case. Most patients with CLL probably have some involvement of the liver. The cells are kind of passing through. Some patients, it does become more prominent, and you can see liver test abnormalities. So depending on which liver test abnormalities, we need to be a little bit careful in terms of starting the pirtobrutinib and dosing and so forth. But yeah, in principle, it should work for CLL in the liver.
Am I reading between the lines here that you think that there's a shift towards, not just with pirtobrutinib and maybe nemtabrutinib, but with the already approved BTK inhibitors towards maybe limited duration with a partner of either obinutuzumab or venetoclax or some of the new drugs in development, so sonrotoclax and others like that? Do you think that we're going to see a shift that way, both frontline and in relapsed refractory?
I think we're getting there. There's accumulating data about the benefits of these time-limited regimens. I think venetoclax obinutuzumab, which is kind of the original time-limited regimen with targeted therapies for CLL, is a good example of that, where we're seeing 6 years of data now showing excellent responses with just 1 year of therapy. We see how side effects decrease dramatically once patients get off treatment. And I think newer regimens that are all oral regimens are coming, and that will be particularly appealing as well. For example, we expect to see data from a big study of acalabrutinib with venetoclax coming soon. And if that leads to an approval of that regimen, then we'll have a way to deliver a time-limited treatment without the need for any infusions. And I think there's a lot of potential benefits to that from a medical perspective. It's also nice to not be hit with copays year after year for a continuous BTK inhibitor. So there may be some practical advantages as well.
Walk me through. I know you touched on this, and you knew that this question would be coming, but you've got somebody who's just failed a BTK inhibitor, and I know that and they have not had venetoclax yet, and I know that this is off-label, but you can still get it. How do you just tell me about your discussion with the patient about whether they should go on pirtobrutinib or venetoclax or a clinical trial, or talk to me about that discussion, because I think that's really pertinent.
Yeah, so these are long conversations. Certainly if I have a good clinical trial, I think a patient's a good fit for, that would often be my recommendation to try to explore the latest and greatest, so to speak. But in the absence of a clinical trial, I think that we still probably have longer term data for venetoclax in this context. It's true that a lot of our time-limited venetoclax data is for patients who have only previously had chemoimmunotherapy. That's the so-called Murano study. It's not so much for patients who have had BTK inhibitors, but nonetheless, I think if patients are willing to go through the ramp up of the venetoclax with the monitoring for the first 5 weeks and so forth. It's nice to have that prospect of a time limited treatment of 2 years and then potential to stop. And it's a labeled use for the drug, et cetera. With pirtobrutinib, again, it's off-label use to use it second line, but there is something very appealing about the convenience of using it there, especially a patient who's been used to being on a covalent BTK inhibitor, and to just switch to pirtobrutinib, it's usually pretty straightforward. There's not a lot of monitoring that needs to take place. And it's a very well-tolerated drug. So, I think you really have two great options there. I tend to still lean a little bit more toward venetoclax, but for patients who want to use pirtobrutinib next, they could probably use venetoclax after that, and that's okay too.
Last question, and there's lots more, and people can send those in. But what do you see? I'm asking you to look into the future. Somebody's failed a covalent BTK, a non-covalent BTK, and venetoclax. What do you see on the horizon? What's got you excited as a researcher?
So there's actually a few things that are very exciting right now, and a lot of this is brand new data that we've just seen in the last few months, including at the European Hematology meeting just last month. But I'd say kind of three things come to mind. One is that we did have Lysocell, the CAR T product, approved, as I mentioned, in March. It's only working in about 20% of patients in terms of inducing complete remission, but certainly for those patients, it's been very durable and exciting to have that as an option. But we've also seen very surprisingly good data for what's called BTK degraders. And I'm going to have to come back and do a whole other program on BTK degraders. But this is yet another way to target BTK compared to covalent and non-covalent, where it actually is a drug that targets the BTK protein for destruction in the cell. So it's targeting it in a very different way. And because of that, we're seeing very dramatic responses, even in patients who've been through covalent, non-covalent inhibitors and venetoclax. Most of those patients are still having a response to these BTK degrader drugs, which are oral and pretty well tolerated as well. So I think that could add a whole additional class of BTK inhibitors if that looks good with larger numbers. And then the final thing, which is probably the furthest away on the horizon, is something called bispecific antibodies. And we've just seen a really early hint of how these work. But these are drugs that target the CLL cell and your normal T cells in the body and bring them together so that the T cells can more effectively kill CLL cells. And a drug called epcoritamab was explored in a small group of 23 CLL patients who had had all the different prior treatments and really didn't have other good options. And about a third or more of those patients had a complete response to epcoritamab, and generally with good tolerability as well. I think, Brian, you're very familiar with this story, and I'm very excited about that initial data set. And there's a lot of studies of epcoritamab and other bispecific antibodies now getting off the ground. So it's a lot to look forward to right now in CLL.
Yeah, thank you for that. I think we have to move on now. So I wanted to thank you for answering all these questions. This is so great. Once again, we want to thank Lilly for their educational grant that has made this event possible. Thanks for joining us today. A big thanks to you, Matt. This was really very helpful. Just a reminder that we'll be emailing you a link for the event survey. Please take a few minutes to provide feedback so we can do our best on future events. This virtual event was recorded and should be available to you in the next 7 days. And if your question wasn't answered, please send it to info@plexuscom.com. Please remember the CLL Society. We're invested in your long life, and you can invest in the long life of the CLL Society by supporting our work. Thanks so much. Stay strong. We are all in this together.